Tonight's discussion, the fifth in our spring 2007 lecture series, introduces you to the concept of external counter pulsation, and specifically to the utility of enhanced external counter pulsation in the treatment of various cardiovascular syndromes. My name is James Roberts. I'm board certified in internal medicine and cardiology, and I've been practicing invasive and integrative cardiology in Northwest Ohio over the past 20 years. I'm the medical director of comprehensive heart care, the Advanced Magnetic Research Institute of Northwest Ohio, and over the past decade, the Enhanced External Counter Pulsation Center of Northwest Ohio. Enhanced External Counter Pulsation, which we'll refer to as EECP, is a novel, no longer new, non-invasive, negligible risk, outpatient approach to the patient with advanced or recurrent coronary disease that is remarkably effective, yet extremely low in cost. We'll discuss the physiologic basis for EECP, and I'll present a number of studies documenting its biochemical and clinical effects. We will discuss the history of EECP, its development here and in China, and I'll present numerous clinical studies documenting its efficacy. We've talked about EECP as part of the integrative approach to the patient with cardiovascular disease, and it's discussed in Reverse Heart Disease Now, a patient manual of integrative cardiology written by myself and my colleague, Dr. Steve Snyder and Steve Sinatra, and you can learn more about EECP on our website, heartfixer.com. But before I get into the more technical aspects of my presentation, let me present you one case study so you can get a feel for the revascularizing power of this technique. LF presented in August of 1998 with new onset chest discomfort. Her symptoms did not respond to medical therapy in the emergency room, and she underwent an urgent angiogram. This demonstrated a 30% narrowing in the left main coronary artery that governs blood flow to 2/3 of the heart muscle. Now that 30% narrowing was not a problem. Before a narrowing can really restrict blood flow, it has to be a 50% narrowing. So the left main narrowing was not the issue. The problem was a 90% narrowing in the left anterior descending that serves the front of the heart. And her symptoms were not responding to medical therapy. Revascularization was needed. When they thought about doing a balloon angioplasty and stent, the problem was the location of the blockage was at the very beginning of the vessel, such that when you blow up the balloon to dilate the left anterior descending, you could rough up the left main, making a bad situation worse. So she underwent urgent revascularization. Bypass surgery was carried out. A left internal mammary to left anterior descending graft was performed. The surgery went well, but she had trouble that night. They took her back to the operating room, opened her up, everything looked good. They sewed her up again, she went home, and she came back 3 weeks later with pain. Repeat angiography demonstrated that the graft was dysfunctional. A 90% narrowing had developed at the junction of the graft and the artery. She was back where she started. So at that point they did the balloon angioplasty and stent because they had no other choice. They sent her home, came back with more chest pain. Repeat heart cath shows what they were worried about happening with the stent did happen. Not only had she re-narrowed in the stent, but the left main had been roughed up. So now she has a 80% left main narrowing, the 90% left anterior descending, and it had spread to involve one of the branches. So 2 vein grafts were placed, but the left anterior descending itself was too small for a vein graft, so she did not get complete revascularization. And as you would expect, she continued to experience chest pain, despite drug therapy that made her miserable. When she saw us in January of '99, she's having pain at rest despite medications. She could walk 7 minutes and 48 seconds on the treadmill. We could bring out ischemia, supply-demand mismatch, and we saw evidence of a heart attack involving the front of the heart that occurred throughout all this surgery. We treated her with external counter pulsation over 7 weeks. Her pain went away. We could cut back on her medicines. She could now walk 10 minutes on the stress test. We could no longer bring out any ischemia. This was pretty good. We were delighted. We were just delighted with LF's response. She was pleased. Her insurance company, after spending about $250,000 on all this that didn't work, was happy to spend $3,500 on ECP that did. We began to work with her medically, risk factor reduction, chelation therapy. She had some boosters of ECP. She did not set foot in the hospital for her heart. She was bowling and twisted her shoulder and got scared and came in and had a stress nuclear study in April of '03. She went 9 minutes and 24 seconds and there was no ischemia. They retired, they moved out of state, but this is still just a wonderful outcome, and this is why we're so excited about external counter pulsation. We can help people who cannot be helped by any other techniques. What are the therapeutic benefits of ECP? ECP provides effective relief of basically all forms of angina. Angina due to endothelial dysfunction, mild, moderate, severe angina due to fixed coronary disease. Its niche is in the treatment of the patient with inoperable disease that is not responding to medical therapy, patients who are not candidates for stents. That is where ECP has its greatest impact, and we can help people with recurrent disease following stenting, laser revascularization, or bypass. You can walk farther on the treadmill, your functional capacity improves, your nuclear scans will look better, better quality of life, fewer hospitalizations and events. Patients with at least one open artery benefit the most, and I'll explain that, and the benefits appear to be sustained in responders, which I'll define later. ECP has been proven to be safe and effective in heart attack complicated by heart failure or shock, heart attack treated with clot-dissolving drugs and angioplasty or stent, unstable angina, and heart failure. ECP is non-invasive. We can carry it out with an extremely low risk to the patient, and it's incredibly cost-effective in comparison to all standard therapies. A full course of ECP costs about what 3 nuclear stress tests costs. Maybe 1/3 the cost of a heart cath, 1/8 the cost of an angioplasty or stent. So ECP is quite cost-effective. How do we get these therapeutic effects? Well, we're not operating on you, we're not changing your anatomy, at least not directly. What we're changing is your physiology. We're working with Mother Nature and optimizing your physiology. Coronary artery diastolic perfusion pressure rises, leading to the recruitment and augmentation of collateral vessels. Your vascular biochemistry changes, favoring angiogenesis. You make vascular endothelial growth factor and nitric oxide. Using physics and biochemistry, the blood supply to the heart, myocardial perfusion improves. Your afterload falls, your blood pressure decreases, endothelial function improves, you make nitric oxide and you vasodilate. Cardiac output and peripheral blood flow increase. Cardiac output increases not because you're whipping the heart, but because you're giving the heart a mechanical advantage. So the demands of the heart muscle for oxygen decrease. Supply of oxygen increases, the demand for oxygen decreases, angina is relieved. Kidney blood flow increases, renin levels fall, urine output increases, salt and water balance improve, diastolic and systolic function of the heart improve, thus external counter pulsation is helpful in congestive heart failure. Blood flow to other organs improves, and there's a systemic antioxidant effect. What I'd like to do now is talk a little bit about coronary anatomy, how we evaluate your chest pain with stress EKG and stress perfusion studies. I'd like to talk a little bit about balloon angioplasty, stent placement, and bypass surgery. This will allow us to best place ECP in a comprehensive or integrative approach to the patient. We have 3 arteries that serve our heart. Actually, we have 2. We have the right coronary that serves the back wall. The left main bifurcates into 2 limbs, the left anterior ascending that serves the front of the heart, and the circumflex, which serves the side of the heart. Now this man has a high-grade 90% narrowing on the circumflex coronary artery. So when he's carrying the laundry up the basement steps, the supply of oxygenated blood is not sufficient to meet the increased demands of the exercising heart muscle. There's a supply-demand mismatch for oxygen. There will be a supply-demand mismatch for ATP energy. So the heart will become stiff, and the patient will be short of breath, and he'll hurt. Because your heart hurts when you don't have enough energy, just as your legs will cramp when you run too far. So he's going to go see his doctor. His doctor's going to do a history and physical and recommend a stress test. Here we put you on a motorized treadmill. Every 3 minutes, when you're getting used to it, we increase the speed and grade. and we look at your heart rate and blood pressure and your rhythm and the look in your eye. How are you handling the exercise stress? And we look at your EKG. When we've pushed you to the point where you have a supply-demand mismatch, when we've pushed you to the point where the oxygen supply is not sufficient to meet the needs of the heart muscle, your EKG will change in a characteristic fashion called ST depression. This is the ST segment. Here it's isoelectric. We push the patient and we get ST segment depression. How far you can walk on the treadmill and how far you can walk before ST depression is brought out is very important. A man who can walk for 10 minutes and doesn't develop ST depression until 9 minutes does not have as much heart muscle at risk as a man that could walk 3 minutes with ST segment depression at 2 minutes. If, as a result of our therapy, you can walk farther than the treadmill, you can walk farther before ST depression occurs, that means we've done you a favor, we've improved blood flow to the heart muscle. Conversely, if I have a patient with chronic coronary disease and I'm doing yearly stress tests on them, and 3 years in a row you can walk 10 minutes, now all of a sudden you can walk only 6 minutes, that means something's changing and I need to evaluate you further. So we're quite interested in treadmill time, time to ST segment depression. We may also do a nuclear study. Here we'll inject into an arm vein a radioisotope that will tag to your red cells, and it will be, the radio tracer will be picked up by the heart muscle proportional to blood flow. So we can do a scan of the heart to get an image as to the adequacy of blood flow. This is a cross-sectional or slice of bread view. A normal person, the left anterior descending, the right coronary artery, the circumflex, blood flows uniform, you get a uniform uptake. In our patient, the circumflex had a blockage, so blood flow to the side of the heart is going to be impaired. We see a bite out of the donut. We know that there's a narrowing, compromising blood flow. And then we'll wait 4 hours and we'll rescan you. And in this patient, it filled in. What happened in those 4 hours to make it fill in? Well, the artery didn't open up, but over 4 hours, enough time has elapsed for enough red cells to wiggle through that narrowing and deposit their tracer. So the defect fills in. As a result of our therapy, we want to convert your ischemic nuclear study into a normal one, showing that we've provided effective revascularization. What we don't want to see is this pattern, a fixed defect. This person's had a heart attack. The artery has closed, the muscle's dead, it's not going to pick up any blood or any tracer. So we want to increase your treadmill time, increase your time to ST segment depression, and fill in your ischemic nuclear defect. So how are we going to do that? Well, in the United States, what we're going to do is a balloon angioplasty or stent. Here we have the heart catheter. We can snake a wire across the narrowing, pass the balloon catheter deflated, blow it up, take out the hardware, and voila, you went from a 90% narrowing to 20% narrowing. You can play golf 2 days later. Well, that's a great idea. The problem is with balloon angioplasty, you're damaging the endothelium, you can't make nitric oxide. The restenosis rate is between 40 and 60%. So as an advance, the stents came out, and now the drug-eluting stents, which retard this restenosis. Now, by the way, if you have a drug-eluting stent and your doctor said to take Plavix, do take the Plavix. Take it for a year. The drug-eluting stents, while they resist restenosis, do not heal well, and thus they're prone to clotting, so you don't dare stop your Plavix. If you do, this wide open artery can clot off suddenly, and the vessel will close without the benefit of collateral flow. Basically the opposite of what happens with external counter pulsation. So if you have a drug-eluting stent, you got to stay in your Plavix. What about this person? All 3 arteries are blocked. Wouldn't it be nice to do 3 balloon angioplasties or stents? 1, 2, 3. Send them to the golf course, 3 days later. Well, in theory that would work, but in practice it's not a good idea. No matter how skillful the operator and how effective the stents or the drug-eluting stents, there's still the potential for re-narrowing. So if we tried to stent 3 arteries, the odds are the patient would be back with some re-narrowing. We would not provide complete revascularization. But the real key reason you don't do stenting on multi-vessel or 3-vessel disease is balloon angioplasty and stenting is controlled trauma. It doesn't happen frequently today, but 10 years ago it was not infrequent that the artery would clot off and close. And the patient would begin to have a heart attack. and then you would be rushed to the operating room for bypass surgery. And you would salvage most of the heart muscle and have only a small heart attack. And that's okay if you have single vessel disease, but consider if we have a patient with 3 vessel disease, the first artery that's tackled is the left-hand ascending, it closes. So the patient begins to have a heart attack over the front wall of the heart. So you're going to rush him up to the operating room. But in the meantime, the other arteries are going to have to pick up the slack, aren't they? Because the front wall is going to stop working. So they're going to be working harder and harder. Of course, their blood supply is compromised. They would not be able to pick up, and the patient would go into shock and die. You wouldn't want that. That's a very, very bad outcome. So that's why we don't do multi-vessel or 3-vessel balloon angioplasty. Instead, this patient's going to get open heart surgery. Surgeon will remove veins, superficial veins from your legs that you can do quite well without. Plug one end into the aorta, the great vessel leaving the heart, plug the other end to the blocked artery beyond the blockage, bypassing the blockage. And then you don't have to worry about these blockages anymore. Actually, they'll close off because blood flow will go preferentially through the open conduit. And this works. As long as these grafts stay open, you'll have good blood supply. Your symptoms will go away. Your nuclear test will improve. Now, 2 out of 3 vein grafts are open at 1 year, and half stay open for 7 years. And as long as they're open, you'll have a good blood supply. Whenever possible, the surgeon will use arterial grafts, the left or the right internal mammary arteries. The proximal aspect of this blood vessel, which really is designed to serve the chest wall, is left attached to the subclavian. That's the artery that serves the arm. The distal end is dissected out, its branches are clipped, and you use it as a bypass graft. Now, the internal mammary artery, its cells make a lot of nitric oxide, so they resist restenosis. These are very durable grafts. It didn't work for our first patient, LF, but on average, 9 out of 10 of these grafts are open at 10 years. So the vein grafts are not, most of them are not going to last 10 years, but artery grafts do. I have many patients that had multivessel bypass. Their vein grafts closed, their lima stayed open, and they've done rather well, because then we'll do external counter pulsation to generate collaterals from the left-hander ascending to the other vessels. What about this person? This guy, one artery's about to close, another did close, he didn't have a heart attack. He didn't have a heart attack at all, even though he closed his arteries. And he has angio when he plays singles, but he does quite well with doubles. Why is this patient protected? Well, because he has collaterals, natural bypasses. We're born with the potential to have sideways or collateral flow between our 3 great vessels. But during health, when blood flow is normal or uniform, there's no pressure differential causing blood to flow sideways from one artery to another, and these natural bypasses collapse. They are not being used. However, in a disease state, they come back to help us. Consider in the good artery or in the right coronary artery above the blockage, the blood pressure is high. In the right coronary below the blockage, the blood pressure is 0. There's no flow. We have a pressure differential. Blood, being a liquid, must follow the laws of physics. It wants to flow downhill from a high to a low pressure sink. So what will happen over time, blood will take the path of least resistance from a high pressure normal artery through these small collateral vessels to the low pressure sink. Over time, these collaterals can dilate up and be as fat as a native artery. So these collaterals are a great thing. See, if your arteries close slowly, Mother Nature will give you collaterals and you don't have to have a heart attack. You have heart attacks when arteries close rapidly, when a 50% narrowing clots or cracks or a stent clots. That's when you get into trouble. But Mother Nature's program, if an artery narrows slowly, you form natural bypasses and you can have silent vessel closure without difficulty. I have patients that have 1 good artery, 2 closed arteries, and they do great for up to a decade. So how do we help our patients form collaterals? There are angiogenic therapies, heparin, that we'll talk about. Heparin promotes angiogenesis. Nitric oxide, that is the chemical that the endothelial cells that line our arteries make. When we exercise, we make nitric oxide. That promotes collateral formation. Exercise. Why do we send you to a cardiac rehab program to have you exercise? When you're exercising, you're increasing blood flow in the good arteries, enhancing the high to low pressure gradient. You're going to force some of that blood through the collaterals, dilating them up. When you exercise, you generate a gentle radial shearing stress against the endothelial cells lining every blood vessel in your body, and that stimulates the release of nitric oxide. So with exercise, your biochemistry and your physics favors the formation and augmentation of collaterals. Think of external counter pulsation as passive exercise. With external counter pulsation, we convert you into a nitric oxide generating factory, and we're going to be shoving blood into the good arteries under pressure, jamming it into the collaterals, opening up and augmenting the collaterals. This is how we help you with external counter pulsation. It's basically passive exercise. How does this all work? Now, these three arteries that we talk about on the angiogram, they drape around the heart. They themselves do not supply blood and oxygen to the heart muscle. They're conduits. They give off arterioles that dive into the heart muscle and divide into the microscopic capillaries that are a single cell thick. The oxygen is exchanged for carbon dioxide through these ultra-thin capillaries. Now consider when the heart is squeezing, ejecting blood under pressure to meet the needs of the body. If your blood pressure is 140/70, that means the heart is ejecting blood, squeezing out blood at a pressure of 140 milliliters of mercury to serve the brain, the kidney, and liver, etc. Well, when it's ejecting like this, the heart's going to collapse or crimp down the capillaries that serve it. So the heart's going to get only 20% of its own blood flow during systole when it's working. In between beats, we call that diastole. The heart is relaxing. The resistance to blood flow into the heart falls, and coronary blood flow increases. The heart serves the body when it's working, but the heart serves itself in between beats. The heart gets 80% of its own blood in between beats. So if we want to improve blood flow to the heart in a meaningful fashion, our window of opportunity is diastole, the time in between beats. So how are we going to do that? Well, with external counter pulsation, and first of all, we've been doing this 10 years. Here's a picture of us when we first started. This is me without any gray in my hair. But the patient lies on a padded bed. We wrap large pneumatic cuffs, large blood pressure cuffs over the calf, the thigh, and the pelvic region. And we inflate and deflate with compressed air. We hook you up to an EKG on your finger. You wear a plethysmogram to give us a non-invasive capillary waveform. This physiologic data is fed into a microprocessor such that when the heart is entering its resting phase, when our window of opportunity is opening, we inflate the cuffs, calf, thigh, pelvic region. We're going to milk oxygenated arterial blood up out of the lower extremities and generate a retrograde pressure wave, and we're going to jam that blood into the coronary arteries, into your bypass grafts, increasing flow up to 4-fold. Then, when the heart's getting ready to contract again, we deflate the cuffs all at once. So we've compressed the vessels. Now they spring open, and the heart's going to be ejecting blood kind of into a vacuum, into a dilated system. And that will reduce the heart's workload. We call that afterload reduction. So during your 1-hour session, your heart is hyperoxygenated and it is rested. And those of you with a background in cardiovascular medicine, we know this is nothing new. This is the concept of counterpulsation. We have a device called the intra-aortic balloon pump. This is a large bore catheter that we place through the femoral artery in the groin. We advance it up the great vessels till we get about 5 centimeters away from the heart. And there's a large balloon. It's kind of like an angioplasty catheter, only it's bigger. And when the heart is getting ready to eject, we deflate the balloon so the heart is ejecting into a vacuum. When the heart is at rest, we inflate the balloon, shunting oxygenated blood back to the heart. Now, I put in about 100 of these things. No matter how sick you are with a heart attack or heart failure, if I put in the balloon pump, you're going to turn around. It is a very powerful methodology. But there's problems with it. First of all, it's a very large catheter. And I've got out of bed in the middle of the night, put the balloon pump in, the patient pinks up, and their foot turns blue because I shut off blood flow to the lower extremity. And the thing's made out of plastic, so we have to keep you on blood thinners. and the balloon's only going to last for 3 to 4 days. So it's not a permanent therapy, it's a bridging procedure to get you over the hump, get you out of shock until you can have open heart surgery or something else. So it's a wonderful therapy with limitations. Recognizing this, researchers at Harvard about 30 years ago set out to construct a non-invasive balloon pump device to get the benefits without the downsides. And many different contraptions were utilized. Here's one where the patient inserts their legs into a water bag, which is encased in a rigid steel housing, so you could apply positive and negative pressure. And this did help many patients, and I'll present some studies of this device. But there were problems with it. It's a hydraulic system. It's kind of difficult to pump water out quickly, and if your heart rate was high, it didn't work well. Also, this is not a sequential phenomenon. The water would rush in all at once, and blood would get trapped in the calf. So while some of the studies were positive, others were negative, and then bypass surgery and then balloon angioplasty came out, and physicians in the United States lost interest in external counter pulsation, which provides only indirect revascularization, and everybody got excited about bypass and ballooning, which provided direct revascularization. So EECP was lost. But fortunately for us, there were some Chinese cardiologists doing fellowships at Harvard at about this time. They saw in external counter pulsation a concept they could take back to China, refine, and use on a large scale as a cost-effective approach. Because back then, China was really a third world economy. They can't afford clot-dissolving drugs and heart catheterizations, but they could afford external counter pulsation. And 30 years later, with a great deal of Chinese clinical research and advances in technology, external counter pulsation is coming back to the United States. The 3 ECP machines I have were all made in China and imported in the United States by Vasomedical. Somewhere between 500,000 and 1 million Chinese have been treated with EECP. This is their standard frontline therapy. It's an American idea, taken overseas, developed in advance. Now it's coming back to help us. Using the modern day Chinese sequential pneumatic cuff mechanism, we typically treat you for 35 hours, Monday through Friday for 7 weeks. If we're in a hurry or if the patient's out of town, we can do 2-a-days over 3 to 4 weeks. We were the second ECP center in Ohio, and I think the 22nd in the United States when we first started. And there was no one in Michigan, Wisconsin, Illinois, etc. So people would come from out of town for EECP, and we'd want to minimize their time away from home. We would do 2-a-days. But typically we do 1-a-days if we're not in a hurry. Now, this graph comes from a review article looking at the early hydraulic methodology. And they found when the clinicians were able to raise the diastolic blood pressure at least 50%, the patients did well. However, when they were able to increase the diastolic blood pressure maybe only 25%, patients did not do well. So we feel the technical key to external counter pulsation is to raise or augment the diastolic blood pressure. Here's what your waveform looks like. We have systole and diastole at rest, and then we turn on the ECP machine. We will lower the systolic component of the waveform and add the diastolic waveform. This is going to be shunning blood back to your coronary arteries in diastole when they're open and ready to receive it. The technician will adjust the timing and degree of cuff inflation and deflation. I may adjust your medicines to get the right heart rate and blood pressure to find like the right sweet spot to get your best diastolic augmentation. We feel that's the technical key to external counter pulsation. These are what the waveforms look like in real life. This is baseline, this is during ECP. We've generated a diastolic waveform here. This patient underwent chelation therapy that we talked about last week, which makes your arteries more elastic. So he had phenomenal diastolic augmentation. So he was getting a technically quite successful therapy. Here we have a fluid-filled catheter in the aorta, the great vessel leaving the heart. These are the normal unassisted waveforms. Now you turn on the ECP to every other beat. Here's an unassisted waveform. Then you turn on the machine, you get diastolic augmentation, and the next beat is diminished. So we lower the systolic component, we augment the diastolic component. We're doing this at the finger and at the level of the aorta. And if you look within the coronary artery itself, there the waveform becomes bifid normally, but as you turn on the machine, you're going to lower the systolic and increase the diastolic. Here we're back in the aorta with the machine off, then we turn it on at low power and gradually increase the amount of pneumatic pressure applied. You can see we gradually increase the retrograde waveform. ECP has an antioxidant effect. Here we're going to measure malondialdehyde levels. That is a marker of free radical stress for which we might recommend antioxidant vitamins. Here we'll measure malondialdehyde in 35 healthy volunteers, 69 coronary patients randomized to medical therapy alone for 6 weeks or medical therapy plus EECP. Now, the cardiac patients have higher malondialdehyde levels than the coronary patients, than the controls. That makes sense because coronary disease is due to free radical inflammation. Now, 6 weeks of medical therapy had no effect because drugs are not antioxidants. However, with EECP, it generated an antioxidant effect and malondialdehyde levels fell. So EECP provides a systemic antioxidant effect. Nitric oxide is the angiochemical that the endothelial cells lining our arteries make that provide the Teflon coating. They vasodilate the blood vessel, they allow the vessel to resist plaque rupture or a spasm or cracking, and they keep the platelets from sticking. We want a lot of nitric oxide. And here we're going to take 43 coronary patients, treat them with the ECP, and they start making lots of nitric oxide. Our patients will feel better at the end of a week. We haven't grown any collaterals in 1 week, but we're converting you into a nitric oxide generator. You know, when you take a nitro into your tongue, all you're doing is giving yourself a jolt of nitric oxide. We're going to convert our patients into a nitric oxide factory. Conversely, endothelin is a nasty Darth Vader angiochemical. It causes your blood vessels to constrict and clot. And you can see that the endothelin levels fell. Now, as you get 1 and 3 months out, the benefit attenuates a little bit, but the biochemistry remains improved from baseline. So we create nitric oxide, we have an antioxidant effect, we lower endothelin. We're improving your biochemistry. Endothelial function, the status of your endothelium is the most important determinant of short, intermediate, and long-term outcome in the coronary patient. I'd rather have a 90% narrowing with good endothelial function than a 60% narrowing with poor endothelial function. The endothelial cells make nitric oxide and vasodilate. There's many ways we can measure endothelial function, but in one, we'll look at how the artery responds to increased flow. It should vasodilate if the endothelium is intact. Here we have some chronic angina patients, abnormal angiograms, abnormal nuclear studies, impaired flow-mediated vasodilatation. Normal is about 15%, they're 4%. You treat them with 35 hours of ECP, you repeat the study, they're nearly normal. They're now making nitric oxide, their endothelium has been at least temporarily healed. ECP and angiogenic growth factors, we're going to look at 11 patients with stable angina. We're going to measure growth factors. Now, these growth factors have a hodgepodge of names depending upon the organ in which they were discovered, but we'll just use the abbreviations. HGF, FGF, EGF, they promote the growth of new blood vessels, angiogenesis. When you're developing as an embryo, you have very, very high levels. We would like to see high levels in our patients because we want you to grow new blood vessels, especially during ECP. So you do the baseline levels, treat them with the ECP, and you reevaluate, and the HGF rises 27%, the FGF by 19%, the VEGF by 16%. 2/3 of the patients responded with significant elevations in HGF and FGF, and 1/3 with VEGF. So ECP is angiogenic. PET scans, 11 angina patients undergoing ECP. As a baseline, you do a maximal stress EKG, arrest and dipyridamyl ammonia PET scans. PET is positron emission tomography. It is our most accurate nuclear technique. You're looking not just at perfusion, but at the ability of the cells to metabolize a nutritional source, here, ammonia. And you're going to measure nitric oxide levels, carry out 35 hours of ECP, and reevaluate. You see that nitric oxide levels double. We've seen that before. Treadmill time improves by 49 seconds. Time to ST depression, time to supply-demand mismatch, doubled from 190 to 375 seconds because you improve the blood flow. And regional perfusion on the PET scan improves. Here's what it looks like. You've got this black hole. That's an area that's not getting enough blood and oxygen. After ECP, it fills in because you generated collateral flow and you've revascularized. You created a natural bypass around the blockage. This is an animal model. These arteries here are blocked. This artery is intact. You carry out EECP, you repeat the injection. These arteries are still blocked, but you can't tell anymore because there's a Christmas tree of collateralization that was carried out in the animal model. But you're more interested in human studies, so let's take a look at this one. 21 patients with angina. 14 were in class 4, that means they're having pain at rest. 6 are in class 3, that's pain and shortness of breath within 2 blocks, 2 flights of stairs. You give them external counter pulsation using the old-fashioned hydraulic device for 5 days. Now in 18 of the 21, the treatment was technically successful. They had good diastolic augmentation. They raised their blood pressure about 50 points. And of these good augmenters, 17 of the 18 were free of pain by day 4. 1 month later, 10 were in class 1, 8 were in class 2. Class 1 is you can do about anything. Maybe singles tennis and you get some angina. Class 2 means you have to go more than 2 blocks or 2 flights to have symptoms. So they improved clinically. They repeated the angiograms in 11. There was a mild increase in vascularity in 5 and an obvious increase in 5 others. So their angiograms improved and their symptoms improved. Wow, that's pretty neat. But I missed this one. Now, you all expect me to be on the cutting edge. You're not coming to me because you've done well. You're coming to me because you have a problem that is not responding well to what standard medicine has to offer. So you expect me to be on the cutting edge. And here I failed you. This paper came out and I paid no notice to it at all. But in my own defense, when this paper came out, the only thing I was paying notice to were girls. Because when this paper came out, I had hair down to here, Deep Purple was playing Smoke on the Water, and I was a senior in high school in 1973. This just shows we had this technology in the United States. This was done in the United States, published in an American cardiology journal, and we dropped it, which was a shame. But it's now coming back to help us, better late than never. Let's jump forward to the first modern-day American paper. Came out in 1992 from the State University of New York at Stony Brook. This is 18 patients treated with the pneumatic sequential inflation Chinese device. Now these patients all had refractory angina, severe symptoms on maximal medical therapy. They were not felt to be good candidates for balloon angioplasty or surgery. They were stuck. And all 18 were on drug therapy. 8 had undergone a total of 19 revascularization procedures. 7 had sustained a total of 14 heart attacks. All 3 arteries were narrowed in 4, 2 vessel disease in 8. So they're a sorry group of people that were stuck. No one had anything to offer them. They got involved in a research study of EECP. And they had 36 one-hour treatments over 7 weeks. No risk factor reduction maneuvers were employed. And back in 92, we weren't doing much anyways. Their drugs could be decreased by their doctor, but not increased. So if they got better, you would know it was from the experimental technique. You do a maximal stress nuclear study, stress them on meds before ECP. When you're done, you repeat the stress thallium study at the same time. So if you went 5 minutes before, you do 5 minutes afterwards so we can look at blood flow in an apples to apples comparison. And then following ECP, you do a maximal stress EKG to see if you could walk farther. So what happened? Well, they all got better. Angina decreased substantially in all 18. In 78%, there was complete relief of angina during activities of daily living. Most were able to cut back on their medicines. Now let's look at their same distance nuclear study. In 2/3, the defect resolved, it filled in, just as it would with the successful angioplasty, stent, or bypass. In 11%, the defect was still there, but it was less. So in 78%, they were considered responders. Their symptoms got better and their nuclear study improved, consistent with better blood flow. In 22%, their nuclear scan did not fill in. They felt better, but they were considered non-responders. Now, if I give you a drug, I can control your angina by lowering your heart rate and blood pressure. I decrease the demands of the heart muscle for blood and oxygen. But with EECP, these patients walked farther on the treadmill, got their heart rate and blood pressure up higher. They were able to do more work because blood flow would have been improved. Treadmill time increased by 1.6 minutes for all 18. And if you look at the responders, it increased by 1.9 minutes. So they got better. But you ought to get better. If you're going to spend 7 weeks with me, you expect to get a little bit better. The question now is, will the benefit hold? Or will the collaterals attenuate, such as a balloon angioplasty site might re-narrow? So to answer that question, let's look at these patients 3 years later. Now, during the 3-year follow-up period, med changes were permitted, but aggressive risk factor reduction was not carried out because we really weren't doing much risk factor reduction now in 1995. 8 received boosters of ECP. What happened to these patients 3 years out from undergoing ECP when they had nowhere else to go? Well, the non-responders, they got better clinically, but their nuclear scans did not improve. 2 had events. One had an angioplasty, 1 had a bypass, but 2 remained free of disabling angina. Of the responders, 2 had events, 1 was lost to follow-up, 10 remained free of limiting angina, 10 underwent repeat stress thallium study. One guy, it was during winter and he was on vacation in Florida, refused to come back to New York, and I don't blame him. But of those that underwent the repeat nuclear study, no ischemia, no supply-demand mismatch, preservation of initial benefit in 8 out of 10, scan was abnormal, but symptoms remained improved in 2 out of 10. That's a lot of numbers that I'll boil down to as, of the 17 patients available for follow-up, 3 years out from undergoing ECP for otherwise untreatable angina, there's a 23% event rate. Family reverts to abnormal, but severe symptoms do not recur. In 12%, no deaths. Family abnormal and signs remained improved in 59%. No events and free of disabling angina, 76%, which is very, very good. Much better than a group who had not undergone ECP, most of whom would probably be dead or have spent a lot of time in the hospital. What about 5-year follow-up? Now, I'm going to submit to you that your status 5 years out from a revascularization procedure is less related to the relative benefit of the procedure and the skill of the operator as it is to how hard you and your doctor work on risk factor control. But we do have 5-year outcome data after bypass balloons and stents, so it's fair to ask, how are people going to be doing 5 years out from ECP? So here we're going to look at 33 patients treated at Stony Brook. Treatment was initiated between 89 and 92, and 73% had a multivessel disease, 48% with a prior heart attack, 2/3 had a prior revascularization, a sick group of patients. They all get ECP, they all got better clinically, and in 78% the nuclear scan improved, and 22% they felt better but their nuclear scan did not improve. Let's see how they're doing 5 years later, where there was a 12% death rate, 27% required at least 1 admission for an event, but 61% did not set foot in the hospital. And that's really good. When we first brought ECP to Northwest Ohio, we're trying to get the insurance companies to cover it. I would show them this study. Hey guys, 5 years out from unstable angina, 61% not setting foot in the hospital. They liked that, and so did our patients. I can refine the outcome a little bit better. Now, 61% of the group were alive and well, event-free, and had not required a hospitalization. But let's look at it as a function of whether you are a responder with an objective improvement in blood flow or a non-responder where your nuclear scan did not improve. Of the non-responders, the event rate was 43% versus 19% in responders. Death rate was 43% of the non-responders, 4% of the responders. So we want you to be a responder. We want your nuclear scan to improve, and I'll get into that a little bit more later on. Now, how are people doing 5 years out from other revascularization techniques? The CAST study looked at medical therapy versus surgical therapy in patients with coronary disease. In the medical therapy group, 5-year survival was 78%. The CABBAGE trialist study compared bypass with medical therapy in coronary disease. Survival at 5 years was 90% with surgery, 84% with medicines. The Berry study compared angioplasty with bypass. 5-year survival is about 87%. And here we have EECP coming in at 88%. But interpreting these numbers, you need to remember that the patients in these studies were good candidates for medical therapy, balloon angioplasty, or bypass. The patients that we're talking about were too far gone for additional bypass or revascularization. But this shows us that in people too far gone for anything else, after ECP, your 5-year outlook is as good as people who are good candidates for angioplasty and bypass who undergo those therapies. It just shows ECP is a powerful technique. ECP is not just an American technique or a Chinese technique. ECP is being utilized around the world. Here's a paper from Indonesia, 2 to 8 year follow-up of 117 patients treated with external counter pulsation and 198 match patients treated medically. At long-term follow-up, the death rate is 10% with medical therapy, 4% with ECP. Heart attack rate, 5% with medical therapy, 2% with ECP. In China, 8-year follow-up of 100 patients treated with ECP versus similar patients treated medically. Symptoms remained improved at 8 years in 21% of the medical therapy only group, 74% medical therapy plus ECP. Death rates 30% with medical therapy, 9% with ECP. Now in China, if you're treated with ECP, you'll receive a periodic booster. Here in the United States, the way our insurance system is set up, before we can help you, you have to be sick. So we can't do maintenance ECP just because we think it's a good idea. But if we did, and we could keep improving your endothelial function, our patients would do quite well, and we would save a lot of money and do a better job of keeping our patients out of the hospital. And someday, our mode of medicine will change into one where we can do intelligent preventative and maintenance therapy. But I have a few patients who have the right insurance who have undergone maintenance ECP, and they've done quite well with that. Who benefits from ECP? Well, let's see. Your pain goes away. We can cut back on your medicines. You walk farther than the treadmill. Your nuclear scan gets better. Your short, intermediate, and long-term outcome is improved. It's very inexpensive, and it's hard to hurt you. Everybody with coronary disease will benefit from ECP across the board, period. Everybody gets better. It's a great idea. But the real question is, who's going to benefit the most? When I had only one machine and a waiting list, who do I bump to the head of the line? Who needs it the most? Conversely, are there patients who will not benefit from ECP? Are there factors that argue against success with ECP? If we're on the fence, ECP versus bypass surgery in an elderly patient, what factors would push me away from ECP and more towards bypass? Can we predict who will be a responder? Whose nuclear scan will improve? Because if you're a responder, then you're going to get the favorable long-term outcome. This study was done to answer these questions. Can clinical and angiographic parameters, findings, predict who's going to respond and improve their nuclear study? We're going to look at 50 patients with chronic angina, look at their clinical characteristics, age, gender, diabetes, smoking, heart attack, ejection fraction. That's the percentage of blood the heart ejects with each beat. It should be 50%. If you've had a heart attack, it'll be below 50%. And you look at the clinical characteristics, then you do an angiogram and record the number of vessels with 50 to 70% narrowings. And if it's just one vessel, you have single vessel disease, two vessel disease, etc. Then you do a stress thallium scan, treat them all with the ECP, then repeat the stress thallium scan the same distance, and then you correlate the clinical and angiographic characteristics with the odds of success. And the clinical and demographic parameters were not at all predictive. But they found that the angiographic picture was predictive. And you can think about this for a moment. Who's most likely to respond to ECP? People with 1, 2, or 3 vessel disease. And the point of ECP is to grow natural bypasses from a good vessel to a blocked vessel. So who's going to do best? People with 1, 2, or 3 vessel disease. Well, the results match your intuition. If people with single vessel disease, and I've got 2 good arteries to grow collaterals to the bad artery, 95% are going to improve their nuclear study. It'll normalize in 74%, partial improvement in 21%. 2 vessel disease, and I still got 1 good artery to grow collaterals from, 90% improve. In 3-vessel disease, only 41% are going to improve the nuclear scan. Why? Where am I going to grow the collaterals from? Just from the proximal portions of the arteries before the blockage. The more surface area of good vessel I have to work with, the easier it is for me to form collaterals. Now, a 41% improvement rate is better than a 0% improvement rate if you're otherwise stuck. But if you come to me with 1 or 2 vessel disease, I can tell you with a high degree of confidence you're going to get better. If you have 3 vessel disease, we can still help you, but you're not going to get the same benefit as the guy in the next bed with single vessel disease. You may need 45 or 50 hours as opposed to 35. You're more likely to need boosters. So we can help you with 3 vessel disease, it's more work. With 1 or 2 vessel disease, we have a lot of confidence that the technique's going to work. Now, when we first started here, there was no one else in the area to teach us how to do it. And we were quite concerned that we would provide this therapy correctly. So we kept very careful clinical and outcome data on our patients over the first 3 years. And over our first 3 years, we treated 181 patients. 45 had never undergone prior revascularization. And of our patients with single vessel disease, their functional class score fell and improved from 2.6 to 1.2. Now, class 4 is pain at rest. Class 1 is you're playing tennis. So they've improved from 2.6 to 1.2. Those with 2 vessel disease, they were sicker. They were at 2.9. They also improved to 1.2. Those with 3 vessel disease, half were having pain at rest. The rest were having pain within 1 to 2 blocks. They improved from 3.5, not quite as well, down to 1.8. They did better, and they had no hope. They don't do as well as people with 1 or 2 vessel disease. Here's an example of what we can do in single vessel disease. HJ experienced a heart attack in 1996. His left antecedent closed, and his heart almost shut down. His ejection fraction fell to 20 to 25%. He lost half of his pumping function, and he still had chest pain despite medical therapy. Now, you're not going to do a bypass here because this is a stable situation. The artery is already closed. It can't get any worse, and it looked as if all the damage that could be done had been done. Why would you do bypass surgery if there's nothing to save? So he was kept on medical therapy, but he was feeling poorly. He couldn't work. We began some nutritional therapies, CoQ and carnitine, that we'll talk about in a few weeks. And in January of 97, his ejection fraction was better, 35 to 40%, normal's 50%, but he still had an angina on medicines. When we got our EECP machine, basically about 10 years ago, he's one of our first patients, we treated him, his angina went away, we cut back on his medicine, he was able to go back to work, he could walk 13 minutes on the treadmill without evidence of ischemia. This was great. We had done a great job growing collaterals from his 2 good arteries to his blocked arteries. He was functionally as good as new. He began IV chelation therapy to get toxic metals out of the endothelium, additional nutritional therapies. He had mild angina in 01, 4 years out. He had a 23-hour booster. He felt great. His resting ejection fraction is 45% in 02. He could walk 12 minutes on the treadmill with just mild supply-demand mismatch. In 05, he could walk 12 minutes. Last December, he walked for 10 minutes. I could bring out a little bit more supply-demand mismatch. I suggested a booster of ECP, but he's feeling so good and he's busy at work, he wanted to put it off. But this man is now 10 years out from a devastating heart attack, and basically he was functionally a cardiac cripple. We treat him with EECP and our other therapies, and now he's enjoying a very good life that we hope will continue for many, many more years. Here's a patient with 2 vessel disease. This was one of my very first patients in Toledo. He came in with a heart attack at 86. Heart cath showed 2 arteries are closed, 3rd artery's okay. That's a stable situation, you don't bypass. No point in bypassing closed arteries. And 3 years later, he had a stroke. And then we really started to get involved in risk factor reduction. This was about the time I was getting into antioxidants and fish oils and things like that. So we worked hard on his risk factors, and he did very, very well, and he was exercising. Then he was sidelined with prostate cancer in 96, and back then you were on your back in the hospital for a week. After he got out, he's having more symptoms. We did a dobutamine echo study, and it was abnormal, and I said, we got to do a heart cath because it's been 10 years and we've been doing this risk factor reduction stuff, but there's no way that 3rd artery is not going to block up in 10 years. but I was surprised and delighted to see his angiogram had not changed over the years. The left antral stenting looked good. Why was he having angina? Because he had stopped exercising. He stopped exercising when he was in the hospital. He lost his collaterals. Well, we then had external counter pulsation. We treated him. He did great. He had only a mildly abnormal 9-minute stress echo. Over the years, he's had some recurrence of symptoms, and I've given him boosters. He really fell apart in '06. He developed, his prostate cancer came back. He had lung cancer. His heart rate fell. He needed a pacemaker. He was really falling apart, and I did a heart cath to see what was going on. His left antral stenting was still open, and we did ECP, and he did rather well with that. He passed away recently of his 2 different cancers. So basically, my goal was fulfilled. And my goal when I approach a patient with advanced heart disease, don't take this the wrong way, but it's for you to die of something other than heart disease. And if you do, then I did my job correctly. So if you have advanced disease and you're a high risk for bypass, and instead of doing a bypass, I do ECP and my other things, and 6 to 7 years later you die of something else, not your heart, then I did a good job. So that's my goal, for you all to die of something other than heart. But I don't want you to do it real fast. What about patients that have had bypass surgery that come back with recurrent symptoms because their grafts went down? Can we help these people? I hope so, because your risks with your second open heart are 10 times that of your first open heart. Let's see if ECP can help these people. 60 patients with symptomatic coronary disease. Some had prior bypass, some had native vessel disease, they never had a bypass. You're going to do a nuclear stress test on them, and you're going to do a heart cath. And the patients with prior bypass, if the graft and the artery to which it's attached are both blocked, at least 50%, that would be single vessel disease, and so on. So you decide how many vessels are involved, you do the nuclear stress study as a baseline, you carry out ECP, and you repeat the nuclear scan and see who responded and who did not. Now, those with 1 or 2 vessel disease, native disease or recurrent disease, 80 to 90% improved, as you would expect. In those with 3 vessel disease who had never been bypassed, only 20% improved their nuclear scan. That makes sense, because where am I going to grow the collaterals from? However, in the patients with post-bypass recurrent 3 vessel disease, 80% got better, which doesn't make a lot of sense. So this analysis was repeated in a different group of patients, same result. Patients with 3 vessel disease who have never been bypassed don't do great with the ECP. We can help some of you, but not all of you. But it appears that 1, 2, or 3 vessel recurrent disease following bypass, everyone does well with the ECP. Why is that? We don't know. It may be that the prior bypass somehow conditions your heart for ECP. It also may be because the grafts tie in at the distal aspect of the vessel where the branches are coming off, or it may be that a 50% narrowing in a vein graft still allows a lot of flow. But in any event, when I'm working with the patient with recurrent disease following bypass, and there's a reason to be conservative, age, kidney disease, something like that, I'll skip the angiogram and go straight to ECP. Why put you through the risk of an angiogram when I have a high probability of solving your problem with the ECP? And I will do that, unless there's a compelling reason to be invasive, such as your insurance company forces the issue. But if it's up to me and I can think my way out of an invasive procedure, I'm going to do it. Now, of our first 181 patients over the first 3 years, 58 had a prior bypass. In those with recurrent single vessel disease, they improved from 2.3 to 1.1. Those with recurrent 2 vessel disease, they were sicker, half were having pain at rest. They improved from 3.4 to 1.5. Those with 3 vessel disease also improved. Maybe not quite as much, but they did improve. 37 of our patients over the first 3 years had had a prior stent or an angioplasty that failed, and they all did well. 1, 2, or 3 vessel disease, falling from class 3 down to class 1 to 1.5. 37 had had a prior bypass and a balloon that went bad, and they all improved. So in the literature and in our local experience, patients with prior revascularization or recurrent disease do as well, if not better, with ECP as do patients who have never been revascularized, which is certainly a plus. So far, we've been talking about hard endpoints, treadmill times, admitting rates, nuclear scans. Those are important parameters to us doctors when we're evaluating a technique, but you don't really care. You don't care what your nuclear scan looks like. You want to know, am I going to feel better? Will this improve the quality of my life? This study was done to answer those questions and also to look at, is this going to be a stressful experience? You're coming from out of town, you don't know me, you're going to uproot yourself and stay here in Toledo, or are we going to engender a lot of stress? So what they did, they took a group of patients, treated them with 35 hours of ECP. You do stress thalliums and a psychosocial assessment before and after. 75% normalized their nuclear study. We're going to look at the psychosocial adjustment to illness. Stress parameters were not increased. Conversely, stress with respect to your family relationships was lessened with EECP. Subjective pain and disability assessment, quality of life, number of angina episodes every 2 weeks fell from 3.9 to 0.6. Nitroglycerin requirement from 2.3 to 0.1 tablets. That's not much nitroglycerin. Try breaking your nitroglycerin tablet down into a tenth. Pain severity on a 4-point scale fell. 2/3 still had physical limitations, but they could do more. Let's look at quality of life issues. Sexual function improved in 1/3. That's very important. If as a result of the medicines we give you or poor blood flow, you lose the intimacy, the ability to have intimacy with your spouse, that doesn't have a good effect on your quality of life. And for us guys, that has a devastating effect on our self-image, so an improvement in love life is certainly a welcome benefit. If you have a coronary event, if you have angina, the last thing we want you to do is shrink away from others. We want you to remain integrated with your family and your social friends. And 2/3 felt that their family life and social life improved. Their perceived health condition, ability to work, energy level, sense of well-being improved in all. This is very important. While only 75% of the patients normalized their stress thallium scans, chest pain frequency and severity, energy level, ability to work, overall sense of well-being improved in all. Sexual function improved in 1/3, family life and social life in 2/3. Thus, there's more to being a doctor and helping people beyond improving their objective findings. We want to improve quality of life, and we can certainly do that with EECP. Now, I read these papers, and I got very interested. I read them again and again. I think I read every paper 10 times. Drove the librarian crazy. I got my first machine. Now I have 3 machines. There's been nothing in my 10-year experience with EECP to dampen my enthusiasm. This is a great therapy. The problem was nobody believed us. There was a handful of us doing EECP getting good results, and nobody wanted to believe us. First of all, this isn't what we were taught in cardiology school. We were taught to change your anatomy, not to change your physiology. So it's very difficult for cardiologists to accept this, and it seemed too easy. And the criticism was, well, they're not really getting better. They just think they're getting better. It's a placebo effect. Now, we respect the placebo effect. If you think you're going to get better, you may get better. Your physiology, your immune system will pick up. So we appreciate the placebo effect. In fact, we engender the placebo effect. If you have confidence in me and in the therapy, you're more likely to get better than if you don't. But I don't think that the placebo effect is going to make 95% of people with single vessel disease improve their nuclear studies. I don't think so. But to quell the skeptics and to prove to Medicare and the insurance industry that they should cover this technique, the MUST ECP study was carried out. This is the multi-center study of enhanced external counter pulsation. 139 patients with class 1 to 3 angina, stress EKGs abnormal in all, 2/3 with multivessel disease, 2/3 with a prior revascularization, a sick group of patients. You carried a baseline stress EKG, and then you randomized them to 35 hours of real or sham ECP. Well, if you were here before we began tonight's discussion and saw the movie, during ECP, you know it, you're jumping around on the table. But the subjects in this study didn't really know what to expect. So half got real ECP, half got fake. They come in, they lie down on the table, you turn on the machine, it's making all these noises, and you apply enough pneumatic pressure to balloon up the cuffs, but not enough to have any effect. So they thought they might be getting ECP. So the real ECP patients came in the morning, the fake in the afternoon. They weren't allowed to talk to one another and compare notes. The doctors doing the stress test, analyzing the outcomes, were not aware of who got real and who got fake. So we have a randomized double-blind study of a revascularization technique, and this is unique. We don't have studies like this of angioplasty, stent, or open heart. And I'm not suggesting we should. How'd you like to be in the placebo group in the open heart study? You know, But we do have this with ECP. So let's see how ECP performs in a randomized double-blind format. Treadmill time did improve in both groups. There was a placebo or a training effect. It improved 32 seconds with sham therapy that was not statistically significant. It improved a little bit more, 44 seconds, with real therapy that was statistically significant. Time to ST depression, a more objective marker, did not change with sham therapy. It improved by 42 seconds with ECP. Angina episodes per week did not change with sham therapy, fell from 5.3 to 3.8 with real therapy. Nitroglycerin use per week did not change significantly with sham therapy, fell from 3.3 to 1.3 with real ECP. So ECP is a safe and effective treatment for myocardial ischemia and angina, even in patients with prior heart attack, failed bypass, or restenosis following angioplasty. This is not due to expectation or placebo effect. ECP works. This study was published. Medicare began to cover ECP, and now all the insurance companies will cover ECP to deal with persistent severe angina in patients who are not good candidates for revascularization. And that's the niche for ECP in the United States. However, around the world, ECP is being used for many different cardiovascular syndromes, and it's catching on in the United States in heart failure and perhaps later in the treatment of heart attacks. So let's review some of the studies of ECP in heart attack, heart failure, or other vascular conditions. Let's start with an animal study of acute myocardial infarction, acute heart attack. We're going to take 14 dogs and we're going to surgically ligate. We're going to acutely close off their left anterior descending. They're going to have a full thickness heart attack without the benefit of any preformed collaterals. 8 of the dogs received 80 minutes of external counter pulsation right when you close off the artery, and then again at 5 hours. 4 animals, they have the experimental heart attack without ECP. You then sacrifice the animals and look at capillary density in the 3 layers of the heart muscle, the endocardial layer, the epicardial layer, and the muscular layer. You could see at all 3 levels, capillary density is increased with external counter pulsation. So in the acute heart attack setting, ECP will rapidly generate collaterals, and you would predict that this would spare heart muscle. In China, ECP is standard therapy for a heart attack. This group of patients had persistent pain in the emergency room lasting at least 12 hours that did not respond to morphine. So they were treated with external counterpulsation. And what they found, rapid relief of chest pain within 20 minutes and 96%. The initial EKG findings of heart attack size steadily improved. It improved in 62%. They did 35 lead EKG measures of heart attack size. They improved. 5 had indwelling pulmonary catheters to monitor their hemodynamics. Heart failure improved in 4 out of the 5. Hypoperfusion, poor blood flow, improved, resolved in 17 of 18. Shock in 5 out of 6. Rhythm disturbances resolved in 3 out of 4. Hospital mortality is 5.8%. In other words, 94.2 of these heart attack patients treated with external counterpulsation survived their heart attack and were sent home. And that's as good as we do in the United States. Here in the United States, we can give you clot-busting drugs, stents, balloon angioplasty, bypass. China, a third world situation, can give you morphine and ECP, and they do just as well. This shows the power of this technique. Here's a study of external counterpulsation in the United States using the old-fashioned hydraulic device. 258 patients with acute heart attack presenting in the emergency rooms at 12 academic hospitals in the United States. They all had Killip class 2 heart failure. This dates the study. Killip class 2 is crackles or rows halfway up the chest. So they had moderate heart failure complicating their heart attack. And they were randomized to receive standard medical therapy or 3 hours of ECP or the hydraulic external counter pulsation their first day, depending on how quickly they got to the hospital. Now, hospital mortality in the conventional therapy group at that time was 15%. Those that got at least 3 hours of counterpulsation, it was 7%. Those that got at least 4 hours, it was 6%. Mortality due to pump failure, 14% with standard therapy, 6% and 5% in the external counterpulsation group. Progression to class 3 or 4 heart failure, advanced heart failure, 15% of controls, 7% in those that got at least 3 hours, 6% of those that got at least 4 hours of external counterpulsation. Recurrent chest pain, a bad sign, meaning that there's more damage that could be done. 59% with conventional therapy, 40% of those who were pumped. Discharge in Killip class 1, free of overt heart failure, 59% with control with medical therapy, 40% with external counterpulsation. So external counterpulsation using the old-fashioned inefficient hydraulic device improved functional status, prevented heart failure or attenuated your risk of heart failure, and decreased mortality by over 50% 20 years ago. Now, it is not my practice to treat heart attack in the office. I discourage people from coming to the office with acute myocardial infarction. However, I did have the opportunity to treat one heart attack patient with the ECP. This was not by my intent. CD is a 42-year-old with a marked lipid abnormality, some early kidney dysfunction. In 1999, he had a normal stress echo study. In 2000, he had a mildly abnormal study. He could go 12 minutes, the back wall was a little punk. He had 30 EDHA treatments, and then in 01 had a normal 15-minute stress echo. We began working together in August of 04. He had a mildly abnormal stress echo. We go 15 minutes. I don't want to do a heart cath on him because that's not much heart muscle at risk. We're going to keep up with medical therapy and risk factor reduction. He had some atypical pain in his belly. I really didn't think this could be heart pain, but I thought I'd do a stress test. So we do a stress test. He's having this pain, but he's not feeling bad. He's not looking good. I didn't think it was anything, and I push him. And that was a big mistake because at the end of the stress test, he starts having a heart attack. He had ST segment elevation, showing that I had closed off blood flow to a segment of the heart, and on the echo, the back wall of his heart stopped working. And I felt pretty bad. I'd caused this guy to have a heart attack. I do this about once every 10 years doing stress tests. That can happen. So I said, let's call an ambulance, take you to the hospital, I'll do a heart cath, and we can do a balloon. He goes, nope, I don't want anything to do with that. I don't want to go to the hospital. Are you sure? Nope, doc, I'm not going. I want you to do something for me here. Okay, we walk down the hall to the ECP machine. I give him 50 milligrams of metoprolol, that's a beta blocker, to decrease his heart rate and blood pressure, decrease demands for oxygen in blood. And we pump him for 3 hours, and his pain went away, and his EKG normalized. It just back to normal. So we acutely collateralized the blocked artery. Then he went and had 20 intravenous phosphatidylcholine treatments. That's a European technique that promotes reverse cholesterol transport. And then he had 150 hours of MME to his heart. We'll talk about that next week. We stimulate stem cell function and try to repair damaged regions. And he was in Detroit on some business and had some back pain and went to the hospital. They did a stress echo. He went for 12 minutes and there was no ischemia, nor was there evidence of his prior heart attack. They didn't see the scar anymore. And if you want to learn how to remove scars from your heart, you'll have to come next week when we talk about MME. Let's talk a bit about congestive heart failure. Let's start with diastolic function, the ability of the heart to dilate. You do not want a stiff heart, but of interest, it takes more energy for the heart to relax than to pump. And the first thing that goes bad when you don't have enough oxygenated blood, you're not making enough energy, is your heart gets stiff. We call that diastolic dysfunction. That's why you get short of breath when you're walking up the stairs. So we're going to look at 12 symptomatic coronary patients before and after a 35-hour course of ECP. We look at treadmill time, same distance nuclear scans, natriuretic peptide levels, and diastolic function with a nuclear technique. Treadmill time improves, time to ST segment depression improved, the nuclear scan improved, no surprises there. BNP and ANP, these are proteins elaborated by the heart in response to stress. It is our best laboratory marker of diastolic and systolic function and congestive heart failure. These markers fell. The heart was being de-stressed. Left ventricular filling rate, the elasticity of the heart, the compliance of the heart, improved significantly. So we're making more ATP, the heart is relaxing better, it's less stiff, it feels better. That's why you can walk farther with less short of breath. And this would suggest a potential benefit in congestive heart failure, which is always characterized by a stiff, energy-starved heart situation. Let's look at the lung-heart ratio. 10 symptomatic coronary patients, all on medical therapy, 8 of the 10 with a prior heart attack. You're going to evaluate the lung-heart thallium uptake. When we inject this nuclear material, if the blood pressure behind the heart is high, because the heart is not pumping blood forward or the heart is stiff, there's a backflow into the lungs begin to fill with blood and they'll pick up the tracer. So the greater the lung to heart ratio, the stiffer the heart, the worse the heart's pumping function. This correlates with you being short of breath with physical activity. It can be a marker of diastolic or even systolic function. So you're going to do this baseline study, carry out ECP, and repeat it 1 month out and then 6 months out from ECP. The resting lung-heart ratio falls from baseline to 1 month and post-ECP, and it stays improved 3 months out. With stress, the lung-heart ratio will rise because the heart can't keep up, but it improved with ECP. So the heart is less stiff, it's functioning better, the lung-heart ratio falls, the lung-heart ratio with exercise falls. This correlates with you can do more with less shortness of breath. Diastolic function is improving. Let's look at systolic function, the contractility, the pumping of the heart, the ejection fraction. If your heart fills with 100 cc's and you eject 50 cc's, your ejection fraction is normal at 50%. As your heart function falters, your ejection fraction falls. Let's see if we can increase the ejection fraction with ECP. 14 consecutive coronary patients undergoing ECP for refractory angina. You do a dobutamine chemical stress echo, you hold their medicines, carry out ECP, repeat the study. And you see the resting ejection fraction rises from 47 to 52%. The exercise, the stimulated ejection fraction rises from 65 to 70%. Here's the paired raw data for their series of patients. So diastolic function and systolic function are improving in people with coronary disease. Well, what's going to happen in people with frank congestive heart failure, whose hearts are stiff and punk and you're short of breath and you require diuretic therapy, etc.? 26 patients with stable heart failure, meds optimized. Their ejection fraction's 23%. That's pretty bad. 50% is normal. 9 had ischemic cardiomyopathy, multivessel coronary disease with prior heart attacks. 7 had non-coronary cardiomyopathies, just a muscular problem. The arteries were fine, the heart was punk. Carry out baseline studies, 35 hours of ECP over 7 weeks, reevaluate 1 week and 6 weeks out. Treadmill time increased by 21% with ECP, and the gain was fairly well maintained at 6 months. Peak oxygen uptake, a measure of aerobic fitness, improved a little bit early after ECP, but of interest 6 months later it improved even more. So this conditioning effect was sustained. The increase in peak oxygen uptake was similar between the coronary and the non-coronary patients. So you're not helping them just by making collaterals, you're having an independent beneficial effect that has nothing to do with collateralization. So you're helping heart failure per se. Improvement in quality of life improved at the end of ECP, and it was even better of 6 months out. Overall, and in the ischemic and in the cardiomyopathy people, the ischemic people continue to improve, the cardiomyopathy people maintain their gain. That led to the large PEACH study. This is 187 patients with mild to moderate heart failure. 95%, most of them were on drugs for heart failure. They were well medicated. The mean ejection fraction is pretty sad at 26%. 2/3 had coronary disease, 1/3 had non-coronary dilated cardiomyopathies. Your baseline evaluation is exercise time, and as a marker of success, they wanted to see could you go an extra minute from your baseline. They looked at oxygen uptake as a marker of success. It was a 1.25 milliliters per minute per kilogram increase, and the Minnesota Living with Heart Failure score. You get 7 weeks of ECP, you reevaluate at 3 and 6 months. Now, 25% of those with drug therapy alone increased their treadmill, their walking time by a minute, 35% with drug therapy plus ECP. That was not statistically significant. An oxygen uptake increase above 1.25 occurred in the same amount in both groups. So for the purposes of their preordained outcomes, the study was not successful. However, if you look at the raw data, those that were randomized to drug therapy alone, 1 week, 3 months, and 6 months out, their exercise duration was decreasing. Those with ECP, they improved and they maintained their gain. Change in oxygen uptake improved with ECP at 1 week and 3 months. It deteriorated with medical therapy. At 6 months, both groups had deteriorated, but the ECP group much less. Change in exercise duration increased with the ECP. Change in exercise duration, these are the ones with coronary disease. These are the patients without coronary disease. So it wasn't that you were improving collateralization, you were improving heart failure. So for the purposes of the study, they said it was not successful. That's because they had some strange outcome criteria. But if you look at it objectively, looking at the raw data, ECP had a significant effect. They looked at this again, and the New York Heart Association functional class improved, and their symptom scores improved. Now they looked at it again, only focusing on the older patients, those who are age 65 or older. This was the PEACH study. We'll call these people older peaches. They were on optimal medical therapy, average ejection fraction 26%, same experimental protocol, and here there was a statistically significant benefit. More were able to increase their walking time by 60 seconds, and there was a statistically significant increase in oxygen uptake. So this shows that ECP does improve functional status in heart failure, whether due to coronary disease or dilated cardiomyopathy. And we're hopeful that based on this study and the studies that follow, Medicare will begin to cover ECP in congestive heart failure. We know it works, but they didn't really show this slam dunk effect to convince Medicare. So more studies will be done. But we know it works, and I've treated people with heart failure, and they've gotten better. Let's look at ECP in angina patients that also have heart failure. That's the type of patients who I would typically see. Let's look at change in ejection fraction and 1-year status. 130 consecutive patients, class 3 to 4 angina and heart failure, mean ejection fraction 33%. Before ECP, you look at functional status and ejection fraction, event rate over the preceding year. You treat them with ECP, you repeat the baseline measures, follow them for 1 year. Mortality was 5%, and 6 of the 7 deaths occurred in those with class 4 heart failure. That's symptoms at rest, and their 1-year mortality should be 50%. So that's a low mortality rate for this type of patient. Of the survivors, the ejection fraction rose by 24%, from 33 to 41%. Hospitalizations per year fell by 72%. These patients, on average, had 1.8 hospitalizations over the year before ECP. Post-ECP, only 50% required admission. That's fantastic. I hope Medicare and the insurance companies are listening. Fewer hospitalizations, lower expense. Seems like a good idea for the insurance industry, for Medicare, and for all of you. New York Heart Association functional class improved by 28%. The sicker the patients, the greater the improvement. The class 4 patients improved by 2 classes, class 3 patients by 1.5 classes. No ECP-related adverse reactions or dropouts. That's not the case when we're doing stents and balloons and bypasses. ECP and angina patients with pump dysfunction, ER visits, hospitalization at 6 months. 233 patients with class 3 to 4 angina, pain at rest or within 2 blocks or 2 flights, and pump dysfunction, a sick group of patients, most with multivessel disease, prior heart attack, average ejection fractions 30%. You're treating with 35 hours of ECP, complication rates below 4%, 44% drop their nitro, 71% improve their functional class. Let's look at the number of ER visits and hospitalizations 6 months pre versus 6 months post ECP in this sick group of patients. Let's look at 6-month event rate. Pre-ECP, 42% had to go to the ER at least once. Post-ECP, it's 10%. Hospitalization rate falls from 63 to 19%. Event frequency per patient, 1.9 pre, 0.17 post. Hospitalization rate per patient, 1.8, 0.25. They got better, and we keep you out of the hospital and out of the emergency room. Good idea. ECP and angina patients with pump dysfunction, 2-year outcome. Many of my patients participated in the IEPR, that's the International ECP Patient Registry Study. We all contribute our patients and outcome data, and we pool it, and then you can derive a great deal of information, and many articles were published. We're going to look at patients with class 3 to 4 angina and pump dysfunction, ejection fraction 35% or below. A sick group of patients, they get ECP. You look at functional status and quality of life before, after ECP, and at 2 years. 83% 2-year survival, 81% without heart failure, 70% event-free, very good for this type of patient. Angina class. In purple is class 4, in green is class 3. So in 94% of the patients, they're having symptoms at rest or within 2 blocks, pre-ECP. Post-ECP and at 2 years, maybe 20% are having class 3 or 4 symptoms. So their functional status improved. Quality of life, 54% had a fair or poor quality of life before ECP. Post-ECP, only 25% have a fair or poor quality of life. The rest, their quality of life had improved. We've been talking about ECP improving coronary perfusion. But why shouldn't ECP improve perfusion or blood flow to the other organs of our body? And indeed, it does. Blood flow to the kidney increases by 21%. Sodium and chloride excretion from the kidney increased by 100%. Urine production increases by 60%. Any of you who have undergone ECP know this. We're improving blood flow to the heart. The heart's pumping more blood flow to the kidney makes more urine, your bladder fills up, and we're pounding away at your bladder, so you have to stop and take a break and empty your bladder. So we're improving blood flow to the kidney and kidney function. Renin, a vasoconstrictive hormone, and endothelin, a vasoconstrictive atherogenic hormone, also fall. If we look at the effect of ECP at 200 millimeters of mercury pressure or the usual 300 millimeters of mercury pressure, we're going to be improving blood flow to the coronary arteries, to the brain, to the liver, to the abdominal aorta for the pelvis and kidneys by 88%, to the iliac artery that feeds the leg and the pelvic organs by 144%. Now, let's look at the effect of ECP on erectile dysfunction. What causes erectile dysfunction? Poor blood flow to the pelvic organs and endothelial dysfunction. Not enough nitric oxide. How does Viagra work? By blocking the breakdown of nitric oxide. How does ECP work? By turning you into a nitric oxide factory. Will ECP help with erectile dysfunction? 13 men without coronary disease, with a stable sexual relationship, NDD, you treat them with 35 hours of ECP. Before and after, you look at penile artery, peak systolic blood flow with a Doppler probe, quality of erection on a 4-point scale, and of more relevance, percentage of attempts at intercourse that were successful. Penile artery blood flow doubled, quality of erection improved. Before ECP, 6 of the men, sex was successful with 20% of the attempts only, and in 7, erectile dysfunction was severe. Post-ECP, Only 2 of the men could not enjoy sexual activity. The rest had improved. Erectile function had improved because you're making nitric oxide. What about erectile function in coronary patients, the people who I see? 120 patients with class 3 to 4 angina, 30 consulted their doctor for ED, 30% were on Viagra. There's a scale to grade the severity of erectile dysfunction, the IIEF, International Index for Erectile Function. It was all abnormal. Extensive cardiovascular disease, they're on multiple drugs like most of my patients would be. Treat them with 35 hours of ECP, angina improved in 89%, functional status in 63%. Let's look at the effect of ECP on erectile function and sexual function in coronary patients. The IIEP score improved from 10 to 12. Satisfaction with intercourse improved from 4.2 to 5 on this scale. Overall satisfaction with life improved because your heart's better, your love life's better, life is better. Libido didn't change, but libido is related to testosterone, not nitric oxide. You would not expect that. Orgasmic function improved from 4.2 to 4.6. Now I read this paper and I thought about it and I asked, how do you actually quantify orgasmic function? You know, I don't know. I always sort of thought it was like an all or nothing thing. But in any event, orgasmic function improves with ECP. You don't get that with open heart surgery. Keep that in mind. ECP and microvascular angina. Here we're going to talk about nitric oxide. 21 patients with syndrome X, microvascular angina, typical angina refractory to medical therapy, abnormal stress studies, but their arteries look good. Their problem is they're not making nitric oxide. This is akin to having a migraine headache. The arteries are normal, the brain is normal, but the blood vessels dilate and constrict inappropriately. These patients, they can't make nitric oxide. They're large and their small vessels vasoconstrict and they have severe angina. Treat them with 35 hours of ECP, reevaluate. Canadian functional class fell from 3.8 to 1.4 post-ECP. 6 months later, it's 1.2. 6-month stress test, full resolution of the ischemic defect in 16 of 17. At 1 year, angina remained improved in 20 of 21. At 19 months, only 1 event. So in these people who suffer from nitric oxide deficiency, endothelial dysfunction, ECP healed the endothelium, converted them into nitric oxide generators, their symptoms went away. ECP benefits in class 2 angina. Now, Medicare and the insurance companies will cover ECP in class 3 and 4, symptoms at rest or 2 blocks or 2 flights. In people who are not good candidates for angioplasty or bypass, they make it difficult for us to apply ECP. I think that's dumb, but that is their policy. And the reason this policy was set was the studies that showed that ECP works were done only in those patients. So Medicare will cover something only in the subset of patients in which it's been shown to be helpful. But many patients elect to undergo ECP even when they're not on death's door. And here let's look at people with class 2 symptoms. They had chest pain and shortness of breath, but they had to walk 2 blocks or 2 flights first. Can we help these people with ECP? Well, of the nearly 1,500 patients in the registry study with 2-year follow-up, 92% had severe class 3 or 4 angina, but 8% had class 2 symptoms and elected to undergo ECP. Now, some could have undergone revascularization. They said, nope, I don't want to do that. I want to do ECP. Let's see how they respond. Now, the class 2 patients, they were very similar to their colleagues with more severe angina. They were less likely to have heart failure, less likely to have a heart attack. They were a little bit younger, but otherwise very similar. Angina episodes per 2 weeks fell from 12.2 to 3.1 in those with severe angina. Those with less severe angina, they also got better. Fell from 6.7 to 1.7. Both groups were doing fairly well at 2 years. Current use of nitroglycerin tabs per week, fell in both groups. So you don't have to be on death's door with nowhere else to go to get better with ECP. We can treat mild angina and still help you out, and I feel improves your long-term outcome. We don't have to wait for you to be in desperate straits. Here in Northwest Ohio, most of the patients who are referred to me by other doctors for ECP are too far gone. They have 3-vessel disease, horrible heart failure. I can help many, but not all, because it's a real struggle. And I'd like to get my hands on people well before you're too far gone. So we want people to be thinking about this as, you know, it's always good to have a wide open artery. It's nice to have a wide open stent, that's great, but we don't have to put off ECP until you got 1 foot in the grave, because then we've probably waited too long. We can help you with severe angina, we can help you with non-severe, non-critical angina as well. Heparin adjunctive therapy. 18 symptomatic coronary patients, do a baseline symptom assessment and a stress PET study, treat them with 35 hours of ECP, 7 get ECP with 5,000 units of IV heparin before the procedure. The rest get ECP without heparin. Heparin's a blood thinner, but it also liberates angiogenic growth factors. If you do cardiac rehab, you'll build collaterals, but if you take a shot of heparin or take it sublingually before your exercise, your collaterals will be bigger, you'll have fewer symptoms, and your stress scans will improve. So let's see, will heparin aid ECP-mediated angiogenesis as well as it will aid exercise-induced angiogenesis? Number of nitroglycerin tabs needed every 2 weeks fell from 4.3 to 1.2 with standard ECP. They did a little bit better, 5.1 to 0.9 with ECP plus heparin. Treadmill time improved in both groups, but it improved more in ECP with heparin, 152 seconds versus 49 seconds. That is a big difference. Time to onset of ST segment depression improved from 269 to 295 seconds with regular ECP. They did better with ECP plus heparin, 247 to 354 seconds. K-mono, which is a marker of the nuclear study, did not improve with straight ECP. It did with ECP and heparin. You know, ECP jams blood into the arteries, so we use physics to open up those collaterals, and you make nitric oxide, and that's angiogenic. If we give you heparin, we're independently improving your biochemistry, favoring angiogenesis. So most of my patients, especially those with 3-vessel disease, when we carry to ECP, we will give you an injection of heparin before ECP, or you can take it under your tongue, and we get a better outcome that way. ECP and sudden deafness and ringing in the ears, tinnitus. 39 patients with ringing in the ears, recent onset deafness. They're not responding to standard therapy. You give them ECP for 1 hour for 5 to 10 days. Carotid artery blood flow to the front of the brain improves by 19%. Vertebral artery blood flow to the back of the brain by 11%. Tinnitus decreases in 47% on average by 16 decibels. Hearing threshold increased in 28% on average by 19 decibels. Benefits lasted over 1 year of follow-up. We can also help hearing loss and ringing in the ears with MME, which we'll talk about next week. MME also vasodilates, makes nitric oxide, and encourages angiogenesis and neurogenesis. And we can improve angiogenesis and blood flow to the brain with ECP as well. How about ECP in ocular ischemia, poor blood flow to the eye? A pilot study, 5 patients with acute obstruction of a branch of the retinal artery of the eye. Treat with ECP over 2 hours, do a laser Doppler to measure retinal red blood cell flow. There was no change in blood flow in the normally perfused segments. In the ischemic segment supplied by the blocked arteries, the eye was collateralized, blood flow improved in 26%. That led to a formal study, measure retinal artery Doppler flow rates in 12 control subjects without known cardiovascular eye disease, 28 patients undergoing angioplasty. They had risk factors at baseline and during ECP, and you can see systolic blood pressure fell a little bit more in the controls, diastolic rose a little bit more in the patients, mean blood flow improved in the patients. Here you've got the Doppler waveform at baseline during ECP, and you've created a retrograde, you've created a pressure wave to collateralize the blood vessels in the eye. We had one of our patients, she had had a heart cath elsewhere, showing single vessel non-dilatable disease, and as a complication of the heart attack, a piece of clot or plaque flipped off to her eye. And she had loss of vision in one quadrant of the eye because that retinal branch was obstructed. And we treated her with EECP, and her chest pain went away, and her vision improved because we had collateralized her eye. In China, if you have a stroke, they give you 24 hours to heal to reestablish the blood-brain barrier, and then they treat you with EECP for 3 days in a row nonstop. And they use arm cuffs to acutely collateralize the brain. Adjunctive measures to enhance and extend the ECP effect. Anybody can buy an EECP machine and turn it on, but the real best efficacy occurs when we understand how ECP works, we understand Mother Nature's physiology, we do everything we can to help out ECP and help out Mother Nature to accelerate and extend your effect. We want to improve endothelial function. We have other lectures on endothelial dysfunction. We'll control your risk factors. We'll give you antioxidants, fish oil, and arginine. We'll promote angiogenesis. Certain drugs are anti-angiogenic. We're going to get rid of them, and we're going to give you heparin. We want to restore ATP. We're going to give you carnitine, CoQ, and ribose to help you make ATP. To get more energy from each new molecule of oxygen the heart muscle is going to receive, and that's going to be the subject of the lecture in 2 weeks. Now, of our first 181 patients over the first 3 years, how well did we do? We wanted to make sure we were doing it correctly. We wanted to benchmark ourselves against the literature. 44% of our patients were in class 4, pain at rest. 39% were class 3, pain with 1 block or 2 flights of stairs. Post-EECP, only 1% are class 4, 5% are class 3. Our patient's symptoms improved appropriately. Chest pain improved in 94% of our first 181 patients over a 3-year follow-up period. 56% became angina-free. Mean angina frequency decreased from 7.1 to 1.4 episodes per week. Functional class improved in 98% for the group from 3.2 to 1.5. Treadmill time improved in 90% on average by 22%. Half of our patients were able to cut back on their medicines. Nitroglycerin need decreased to 92% from 6.4 to 1.1 tab per week. 93% over that 3-year period had not required a balloon, a stent, or a bypass. 89% without an unplanned hospital admission. 78% have not set foot in the hospital after undergoing ECP except to visit their friends. No patient died during their ECP. 1 patient experienced a stroke, not during ECP, but between sessions. That was not a complication of ECP, it was her native disease. And when you think about it, the type of patients that we're treating with severe coronary artery blockage, a lot of them are going to have carotid blockage. We've treated people with totally closed carotid arteries. So we had the 1 stroke, and that was really an incidental finding. No patient had an infection, a hematoma, abnormal bleeding, respiratory or kidney failure as a consequence of ECP. We can't say that with open heart surgery and other invasive techniques. Let's look at 2-year event rate before and after undergoing ECP at the ECP Center of Northwest Ohio. Before ECP, this was a sick group. 81% had some form of event, revascularization, hospital stay, etc. Post-ECP, over 2 years, it's down to 22%. Hospital admission falls from 31 to 10%. Heart catheterization from 49 to 28%. Angioplasty or stent from 22 to 6%. Bypass about the same, 5 and 7%. What are the physiologic effects of ECP? Coronary artery diastolic perfusion pressure rises, leading to recruitment and augmentation of collateral vessels. Vascular biochemistry improves, favoring angiogenesis. Vascular growth factor and nitric oxide levels increase. Myocardial perfusion improves. Blood supply, oxygen supply improves. Afterload decreases. Systolic blood pressure falls. Endothelial function improves. Nitric oxide rises. Endothelin falls. You vasodilate. Cardiac output and peripheral blood flow increase. Not because we're whipping the heart, but because we've given the heart a mechanical advantage. So the heart's requirements, demands for oxygen decrease. Supply rises, demand falls, supply-demand mismatch is abolished, angina is relieved. Kidney blood flow increases, renin levels fall, urine output increases, salt and water balance improves, diastolic and systolic function improves, congestive heart failure may improve. Blood flow to other organs improves, we have a systemic antioxidant effect. Thus, ECP provides effective relief in all forms of chronic angina, beginning with angina due to endothelial dysfunction, pure nitric oxide deficiency, mild, moderate, or severe angina due to fixed obstructive coronary disease, angina refractory to medical therapy in patients who cannot undergo bypass or balloon angioplasty or stent, angina recurring following bypass, angioplasty, stent, or laser revascularization. Treadmill time improves, functional capacity improves, your nuclear scans improve, you experience an enhanced quality of life, fewer hospitalizations and events. Patients with at least one artery benefit the most. They are the responders, and the benefits are sustained in the responders. ECP has been proven to be safe and of value in acute myocardial infarction, heart attack complicated by heart failure or shock, heart attack treated with thrombolytic clot-busting agents or percutaneous intervention, unstable angina, heart failure. ECP is non-invasive, the complication rate is exceedingly low, and ECP is cost-effective in comparison to all standard therapies. If you even had an option outside of ECP, most of our patients did not. And this is what it looks like when we're doing it today. I've been giving this talk for 10 years, and at the conclusion of the talk, there's always the same questions. A, how much is it going to cost? B, will my insurance cover it? What are the risks? And are there patients who could not be treated with ECP? Now, I've said that the complication rate of ECP is negligible. How can it be negligible in people with severe heart disease? Well, that's patient selection. That's my job. Yes, there are patients who cannot be treated with ECP. What conditions would preclude safe ECP? Think about that for a minute. First of all, significant abdominal aortic aneurysm. If your aorta is a big balloon, it's about to blow up, we don't want to be pulsing blood flow up and down that. So that's why I'm going to examine you and ask you about that. Having said that, I'm sure that I've carried out ECP on people with aneurysms and I didn't know it. Because if you're overweight, I'm not going to feel it. We don't do CAT scans on everybody. I have never heard of anyone's aneurysms blowing up during ECP in the United States. We're still going to think about it, but it doesn't appear to be a huge problem because it just hasn't happened in 10 years. Not in my practice, and now there's 1,000 people in the United States doing this. Greater than moderate aortic insufficiency. The aortic valve opens to let blood leave your heart. It snaps shut to keep blood from running back to the heart during diastole when the heart's at rest. With ECP, we're going to be shunting blood back to the heart in diastole. If the aortic valve is incompetent, that pressure wave will rush back into the heart and cause heart failure. However, if you have enough aortic insufficiency to be a problem, we're going to hear it on your physical exam, see it on your echo. So that's not a problem. Uncompensated heart failure. Now, ECP is a value in heart failure, but we have to compensate you. Let's say your legs are full of edema fluid. You've got 10 pounds of water on each leg, and you're not on an adequate diuretic to mobilize that edema, and we put on the cuffs, we're going to milk that edema fluid rapidly back to the heart. It's kind of like having an IV of salt water wide open. We'll mobilize this edema fluid back to the heart more rapidly than the weak heart can handle it. We could actually put you into heart failure. So when I'm evaluating you, I may adjust your diuretics to get rid of that edema fluid, and we watch that. We watch your weight, we watch your oxygen saturation, and that allows us to treat people with heart failure with safety. An uncontrolled bleeding diathesis. Let's say you're on Coumadin and your levels are way too high, the barotrauma would make you bruise, so we have to watch that. Now, if you are on Coumadin, we can treat you. We get your INR at 2 or below, and we can treat you with ECP, and we have not had trouble. If you've just had an angiogram or vascular surgery, we need to wait for you to heal up. If you have a heart catheterization with the 4 French, the skinny catheters, I can begin your ECP 2 days later. If you have a larger catheter, I have to wait a week or so. If you have a blood clot, a deep venous thrombosis in your calf, obviously I don't want to massage that clot out of your calf and go to your lung, you'd have a pulmonary embolism. So we always examine you for that, and I've never had a problem. It is happening in the United States, and I think it's because the doctors either had incredibly bad luck or they did not examine the patient ahead of time to make sure they didn't have a blood clot. If you've had a prior blood clot and it's healed, we can treat you. And if you have chronic venous insufficiency, that will heal up too. And in China, ECP is used to treat chronic venous insufficiency. There are some challenges to ECP. We're gating cuff inflation and deflation to your EKG. If you have atrial fibrillation, you have an irregular heart rhythm, it's difficult to get the timing correct. But I can adjust your medicines so your heart rate within atrial fib is fairly regular and we can treat you. If you have frequent PVCs, extra heartbeats, premature ventricular contractions, that disturbs the gating of cuff inflation and deflation. There's an algorithm in the microprocessor that keeps the balloons from inflating with a PVC. Let's say you had an arrhythmia and your heart rate took off at 150. You wouldn't want to be beating at 150 with the ECP. So it will not inflate or deflate for a PVC. But then the air pressure builds up, and on your next beat you get a wallop. And we call it getting a rough ride on the machine. It won't hurt you, but it's very uncomfortable. So if you have a lot of PVCs, I will use medications and nutritionals to quiet down your rhythm. Typically, you're low in magnesium. Almost everybody who has cardiovascular disease in the United States is low in magnesium. Almost everybody that comes in for ECP is low in magnesium. When we see the PVCs, we give you a lot of magnesium and they quiet down and we can continue. If you have a pacemaker, it's a little tricky, but we can work around it. If you have a rate-responsive pacemaker, such that when you're going up and down the steps or crossing railroad tracks, your heart rate picks up, we have to deactivate that feature. Otherwise, when we shake you, your heart rate would go up, and we can do that in the office. If you have lower extremity vascular disease, that's a challenge. Let's say you've got 90% narrowings in the iliac arteries to your legs. I can squeeze your legs all I want, but I can't get that retrograde pressure wave in your aorta. So I can help you if you have lower extremity vascular disease, and actually we can collateralize your lower extremities, but if you have high-grade disease, ECP alone is not going to get the job done. So those are the contraindications and those are the challenges. This is my job to screen you, and if I do my job correctly, and I hope I do, we have a low complication rate, and that's something that we've enjoyed. With respect to cost, no one has to pay for it anymore. Every insurance in the United States recognizes the value of external counter pulsation in advanced coronary disease. Now, most will insist that you have class 3 or 4 symptoms, that is, 2 blocks or 2 flights of stairs, and that you'll be a bad candidate for revascularization. And that's up to me. And that can be a little bit subjective. A 90-year-old is a bad candidate for revascularization. A 45-year-old laborer with single vessel disease, he ought to get a stent. Of course he should. And in between those two extremes, there can be shades of gray. But that's the decision that we make if you're not a good candidate for revascularization, or you're not likely to undergo revascularization at an acceptable risk, then I can treat you with ECP, and insurance companies do not fight me. So it's universally covered for severe angina, and hopefully we'll have coverage of ECP in congestive heart failure. That's all I have to say on external counter pulsation in the treatment of cardiovascular disease. This is a novel, not so new, outpatient, non-invasive, negligible risk approach to the patient with advanced cardiovascular disease that is remarkably effective and extremely low in cost, and I love carrying out ECP. That's all I have to say. Thank you very much for your attention.